Good afternoon, everybody. So I will speak about targeting blood pressure now. So there are many questions about blood pressure and the use of vasopressors in septic shock patients. So the question is which MAP target we have to use. But there are other questions we have to answer first. The first one is why do we use a vasopressor in septic shock and when to initiate a vasopressor in septic shock. The first question is easy to understand and easy to answer because, in fact, septic shock is characterized by a decreased vascular tone due to many mediators. And this will result in hypotension, and this hypotension can worsen organ perfusion. Of course, if we remember the autoregulation curve with the organ blood flow on the y-axis, whatever the organ, the brain, the kidney, etc., and the mean arterial pressure on the x-axis, you know that the mean arterial pressure is a driving pressure for organ perfusion. We have this kind of curve. This is a curve which is with a plateau, which is a physiologic plateau, and there is no change in organ blood flow if blood pressure, mean arterial pressure, moves on this plateau. But if blood pressure decreases below a certain level, a certain critical level of mean arterial pressure, then organ blood flow decreases as well. And this could be the case for the kidney, for the brain, etc. So this is why profound hypotension per se worsens organ hypoperfusion. And this represents an independent risk of death. And we know that for many studies. For example, this study by Varpula and co-workers, it was a retrospective study, but very nice study. They looked at all the predictors of mortality in septic shock patients, and they found that the best predictor was the area under the MAP 65 meters of mercury. So not only the deepness of hypotension is important, but also the duration of hypotension. And also we know that correction of hypotension with a vasopressor allows improving organ perfusion. And there are many studies. For example, this one from the group of Claude Martin in France. They gave norepinephrine to patients with septic shock. You can observe that at baseline, mean arterial pressure was very low, 54 meters of mercury. And they gave norepinephrine, and urine flow increased, creatinine clearance increased, and blood lactate decreased. Why cardiac output did not change? So this was probably an arterial pressure effect. And we also know that correcting hypotension, severe hypotension, also may improve microcirculation. This is one study we did in our group with Jean-François Georget in the past, and we gave norepinephrine to septic shock patients with low baseline value of mean arterial pressure, 54 on average. And we gave norepinephrine, and mean arterial pressure went up to 77 on average. But also we measured STU2, you know, using the spectroscopy, we measured STU2 at the level of the thenar eminence. And you know that STU2 is a tissue oxygen saturation is a marker of hypoxia just below the skin. The normal value is around 82%. And in these patients, we found a baseline value before norepinephrine of 75%, and this increased with norepinephrine. But not only we measured static values of STU2, but also we perform a dynamic test, which is the vascular occlusion test, consisting of inflating a cuff around the upper arm until STU2 decreases below 40%, and we deflate the cuff suddenly, and we look at the recovery slope. And the recovery slope has been demonstrated to be a marker of recruitment of microvessels. And what we observed in our study, we observed an improvement in the STU2 recovery slope when we gave norepinephrine to very hypotensive patients. So it's good also for microcirculation and tissue oxygenation. So when to initiate a vasopressor in septic shock? In fact, it is easy. if we follow the recommendations of the Surviving Sepsis campaign, and I think that we have to follow these recommendations, we know that it is possible to use a vasopressor very early. Early means more or less immediately. If there is a life-threatening hypotension, severe hypotension, and you have to look at the diastolic blood pressure. When the diastolic blood pressure is too low, this is an indication to give a vasopressor. So now the question, which mean arterial pressure target in septic shock? So maybe 65 milliliters of mercury is a magic number. We already saw this number in the retrospective study I spoke about. Maybe it is okay. And also this comes from this study by Ledoux and co-workers. They gave norepinephrine at different dosages, and they tried to achieve a mean arterial pressure of 65 and then 75 and then 85 meters of mercury, and they measured organ blood flows, and nothing changed with all the doses of norepinephrine. So we can postulate that 65 was already on the plateau of the autoregulation curve. So increasing mean arterial pressure above 65 did not result in any effect on regional blood flows. And this is why the Surviving Sepsis campaign recommends now to increase mean arterial pressure above 65, at least initially. But the question is it dangerous to target MAP value up to normal values? You know that in normal people, the normal values of mean arterial pressure is around 85, 90 meters of mercury. Is it dangerous in septic shock patients? Maybe not. This is a study by the group of Rupert Pierce. They measure PTO2, which is the tissue oxygen pressure. And they observe an increase in PTO2 when they increased the mean arterial pressure from 60 to 90 meters of mercury, an improvement in PTO2. This is also observed in this study by Dr. Tooth and co-workers from Brussels, and they gave norepinephrine to patients with a mean arterial pressure of 65, and they increased the dose of norepinephrine to achieve 75 and then 85 meters of mercury. And they measure the STO2 recovery slope I spoke about before. And they observe an improvement in this STO2 recovery slope in patients. And when they return to the baseline value of 65, STO2 recovery slope went down. And this was also observed in patients with SDF device to assess the sublingual microcirculation. The same group did this study. They increased the dose of norepinephrine to achieve a mean arterial pressure of 65, 75, and 85 meters of mercury, and they measured all the SDF variables. And what they observed that the best level, 85, was associated with an improvement in the microcirculation. So not only it's not dangerous, but it can improve in some patients microcirculation. But there are some different results according to studies. This is a study by Dubin and co-workers from Argentina, and they also assessed microcirculation of the sublingual area using the SDF technology. And they examined patients at different levels of mean arterial pressure, 65, 75, 85 again. And what they observed, some patients, they measured capillary microvascular flow index, which is a major variable. And what they observed that some patients were doing better with 65 meters of mercury in green. Some other patients were doing better with 75 meters of mercury. And other patients were doing better with 85. So there is a highly variable response among patients. And this emphasizes the fact that we need to individualize our therapy. I will skip that. So, probably we have to individualize, and maybe we have to target a higher value of mean arterial pressure when there is some history of chronic hypertension. Because in this case, maybe there is a shift of the autoregulation curve towards the right. And therefore, a value of 65 meters of mercury, which is on the plateau of the relationship in case of no prior hypertension, could be on the ascending slope. And maybe in this case, 65 is not enough. You have to increase to be on the plateau. And just let's remember the river study. When we look at the results, we could be very surprised because after 6 hours of resuscitation, the mean arterial pressure was 95 meters of mercury in the famous EDDT group. Maybe it accounts for the improvement in the prognosis, I don't know, but we have to keep that in mind. But in this study, 2/3 of patients were hypertensive before. So this is the reason why with Pierre Asfar and other colleagues, we conducted a study which was a multi-center randomized trial trying to compare two levels of mean arterial pressure. 65 to 70 meters of mercury, which was the low MAP group, and 80 to 85 meters of mercury, which was the high MAP group. And we included maybe 400 patients in each group, more or less. The results are here. The severity of these patients was very high, as assessed by a high SAPS-2 score, high SOFA score, high lactate level, and already also, as Jan Bakker said, patients already received a lot of fluid, almost 3 liters, before randomization. This is the results for MAP. We couldn't achieve to maintain MAP in the low MAP group between 65 and 70 meters of mercury. It was too difficult, but we have still a high difference between the two arms, which is the high target group. The mean value was 85 meters of mercury during the 5 days of the study, and the low MAP group, the value was around 75 meters of mercury. So the results, you know the results, there is no difference in terms of mortality at 90 days. But there was an improvement in terms of renal function and what we call the doubling of plasma creatinine, and also the rate of renal replacement therapy in patients who were in the high MAP group, in the subgroup of chronic hypertensive patients, because we pre-stratified this study and we subdivide in chronic hypertension patients and no chronic hypertension patients. So there was a benefit in terms of renal function with plasma creatinine, but also the requirement of renal replacement therapy. There was no difference in terms of adverse events, serious adverse events, just a small difference in terms of atrial fibrillation rate, but as you can see on the slide, the rate was very low, 6.7 versus 2.8, so it was not a very high rate of atrial fibrillation, new episodes. And so this is just a study which is about to be published in Critical Care. It is an interesting study by a Chinese group. They try to see what happens in terms of microcirculation in patients with prior hypertension who developed a septic shock. And they compare two levels, a level of 65 meters of mercury and a level of usual MAP of the patient before to be sick. It was more or less 93 meters of mercury. And they measure microvascular flow index using the SDF technology at the level of the sublingual area. What they observe an improvement in the microvascular flow index when the patient received norepinephrine to achieve a level of MAP of 93 meters of mercury, which was the usual MAP of the patient. Maybe we also have to consider higher level of MAP in case of high central venous pressure. Because in this situation, what is important is the gradient between MAP and CVP. This is the perfusion pressure gradient. So if you have a high CVP, for example 15 meters of mercury, you should think about either to lower this CVP level or to increase the level of MAP to maintain a sufficient gradient between both. And this was well illustrated by this study by Mathieu Legrand and co-workers, and they looked at the mean CVP on the x-axis and the risk of a new or persistent acute kidney injury on the y-axis. As you can observe, the higher the CVP, the higher the risk of acute kidney injury. And it was also observed for microcirculation by Christian Boerma and Janine Shea in this study when they look at the MFI, which is a microvascular flow index, at the level of the sublingual area. They found that the higher the CVP, the lower the MFI. And also for the same reasons or similar reasons, in case of increased abdominal pressure, you have also to think about to elevate your MAP target. And this is what the recent consensus conference report is saying. This is a report by the ESICM, Royal Society of Intensive Medicine, and what this report is saying that you have to individualize your approach to target the blood pressure, and in particular you have to initially target MAP of at least 65, but maybe you have to think about a higher MAP target in case of history of chronic hypertension. So I have to conclude. So the main message of this presentation is that we have to individualize our approach between 65 and 85, which seems to be a safe range. At least 65 meters of mercury, and probably higher if there is some history of chronic hypertension, elevated CVP, or elevated abdominal pressure. Thank you very much.